I think we're ready to rock. Great, thank you. So, hello everybody. I'm super excited to about this week's topic. It's something that for me, I don't know too much about, and I think that's a little bit sad because as a refractive surgeon, I should be knowing a lot about this. And so that's one of the reasons we wanted this topic, is to educate our colleagues, but especially I want to educate myself. So I really want to looking forward to this talk on myopia prevention and management. It's something that's been really talked about more and more lately, especially as some of the recent trials have come out with helping us understand the progression of myopia. And so we're super fortunate to have Dr. Brittany Yelle, an optometrist at PCC, talk to us about myopia prevention and management. Dr. Yelle graduated from the University of Montreal and is with us at Precision Cornea Center, and we're super fortunate to have her with us. She's been really enlightening us a lot about the way we look at myopia, the way we look at contact lenses, ocular surface, all these things. So I'm truly blessed to have her on our team here at PCC. And Brittany, without any further delay, thanks for agreeing to talk about myopia management, and we look forward to your talk.
Perfect. Thank you so much for giving me the opportunity to present today. It's been fun to be a part of the grand round since we started them up here at PCC, and always being in the back of the room, but now it's nice to finally present something that I'm pretty passionate about and that we'll be doing a lot of here at PCC. So this talk will be a little bit different to the other talks in the previous weeks, just in the sense that it's probably more targeted towards the optometrists and techs. Nevertheless, I do think that it'll be very informative for all the ophthalmologists and all the other participants that'll be watching this talk. So the learning objectives for today, I'd like to take a stair-stepped approach in the sense that try to explain what the hype is around this subject. So a lot of people will come up and just say, you know, myopia has been around for quite a while. Why all of a sudden is it becoming important? And why are we getting all this pressure to better screen for it and control it when it's really been there all along? So we'll go over some of the most recent studies that have been out, trying to understand why it's becoming a more important thing to include as screening in our exams, or even prevention, or at that point controlling if it's already there. And then once we understand why it's important, hopefully get everyone on board with that, go on to the different ways we can modify to better screen for it in pediatric exams. So this will be more on the optometry portion of it, and just explaining the different steps that we can take. They're just easy things that we can add into the exam that won't make it all that much longer, but just better target people who are maybe more at risk for developing myopia. Like we'll see in multiple of the studies, often these techniques work a little bit better if the child's not yet myopic, and so that's the important part of screening for it, so we can help them before they actually develop that myopia. And then once we go over the screening, then we can actually understand what has to be included in the myopia management exams themselves. So it makes you go on to the next step. If you're not willing to do or wanting to do myopia management in your clinic at that point, it's just understanding or preparing your patients for when you refer them off to an OD that will be doing the myopia management, just allowing them to better understand what differentiates the pediatric exam they just had for that was covered by OHIP versus the exam now that they're going to have by another optometrist. And then afterwards, we'll talk about the current treatment options that are available for myopia control right now, who the best candidates are. So we've got a lot of tools in our toolbox now. Beforehand, it was pretty sad. We were able to kind of do all the workup for myopia management, but we didn't have all that many tools. And some people, even though we did want to halt the progression or kind of try to slow it, there weren't any options for very high prescriptions and stuff like that. So we'll definitely go over now all the new current treatment options that are available. We've got a lot more of them, who the best candidates are for each one, and what the percentage of control is for each one as well. So just before we get started, I'd like to mention that I have no financial disclosures. And so let's go. So the big question, why is myopia prevention so important, and why now? And before I even answer this question, I once had somebody explain to me by using an analogy and comparing it to another ocular disease that we see a lot of, which is glaucoma, and I'm talking about the optometrist, just because if we think about 20 or 30 years back, optometrists really didn't do a lot for screening or preventing or even treating glaucoma. It really was something that we just referred off, and the ophthalmologist took care of that. And now more and more, we've been doing a lot of management for glaucoma, actually treating it and co-managing it with the ophthalmologists. And if you ask any OD right now, they wouldn't think twice about all the screening things they do in their exam to try to pick out who's a suspect for glaucoma or who has glaucoma, and also all the diagnostic testing afterwards. And so if we compare these to the myopia to glaucoma at that point, you'll see that for right now, the prevalence of it is about equal. And for the future projections, actually, myopia is a lot more important and will become a lot more important in the future. So this may be just, if you do put a lot of time and effort into glaucoma, you'll realize that these are quite equivalent, and at that point, maybe it'll make you interested in trying to prevent for myopia as well. So if we look at the current prevalence of glaucoma and the projections in 2040, so this was a study done about 2014, what they found was that in 2040, there'll be about 111.8 million people that'll suffer from glaucoma worldwide. And if we look at the prevalence of low vision and blindness using the World Health Organization's criteria caused by glaucoma, and take a look at that, this is in Canada, it's about at 7%. So obviously not the most prevalent, not the least prevalent visual impairment using the 2040 criteria, and blindness at the 2400 criteria. But it's obviously there and pretty prevalent. That's why we work so hard for trying to screen for it and treat it if it's there. And so if we look at how we better screen for glaucoma, when the patients come in, obviously they're not going to talk about their IOP, their cup disc, and they probably won't even mention the family history of glaucoma unless you kind of poke at it a little bit. And so we wouldn't think twice about checking IOP, checking cup disc, asking about family history of glaucoma, and if we're suspicious, after that, going on to the glaucoma workup where we do visual field and OCT with RNFL and GCC. And so if we're ready to offer all of this for the glaucoma suspects where we've just seen what the prevalence is, and ready to manage it either with drops or with surgical intervention if we're co-managing with ophthalmology, then why wouldn't we do the same for myopia? So now if we look at kind of the same results for myopia, so the global prevalence of myopia and high myopia and the trends for 2050, this is probably one of the studies that's the most popular right now and is probably what's created the most hype around this subject. It's a study by Brian Holden that was done in 2016. And so what they're showing for 2050 is there's going to be about 5,000 million people worldwide that are going to suffer from myopia, suffer from it. They're going to be myopic. So that's about half the world's population, and 938 million people will be highly myopic, so above -6 diopters. It's about 10% of the world's population. I know right now we're comparing, there's about a 10-year difference between the glaucoma study and this one, but just to give you an overall portrait of how much this is gonna kind of, the impact is gonna get a lot larger for myopia. And if we compare now actually before that, we'll just talk about this last little statement that I read in the study that really stood out to me, and I think it is the statement that actually has stood out to most of the specialists that are doing a lot for myopia management and prevention, is the fact that it is going to become the leading cause of permanent blindness worldwide. And so I think after hearing that statement, it's pretty tough to then say that you're not going to try to work hard and integrate screening into your exams and referring the patients off to the proper specialists. With a statement like that, I don't think we should be choosing whether the patient is fine at a -2, even if they're progressing by -1 each year. It really should be up to the patient to get all the information and know what's available for them in terms of myopia control. And so next off, if we look at the epidemiology, and so the prevalence of low vision blindness caused by myopia now, and so this is for currently, I know it's not in Canada, now we're in Los Angeles, USA, but just to give you an overall view, it's at about 6% using the same criteria, so the World Health Organization, visual impairment and blindness caused by myopia. So just even currently, they're both kind of at the same level in terms of visual impairment and blindness, so quite important. This book, The Pathologic Myopia by Richard E. Spade, I know the picture's a little bit blurry, I'm sorry about that. There's a couple statements that stood out when I was reading this, because often we'll think, what is the big difference between having a -2 myope and having your -6 myope, when in glasses they're both going to see exactly the same, other than the fact that without glasses, I mean, one's more visually impaired than the other. And there are a couple things that stood out to me. This one did as well. So myopic retinopathy, the prevalence of that between being above and below -5 diopters, there's about a 60 times increase in the prevalence of that. So that is a big jump. And just these little things, if you're able to keep up on the most recent literature, We all know that high myopes are more at risk for a lot of things, but we often don't think about how much there is an increase in the risk. And so this was one that really stood out that I thought everybody should hear, as well as the risk with other ocular diseases like glaucoma. So if you really wanted to be, if you're really big into glaucoma, you can start doing myopia prevention to help out with your glaucoma patients as well in the future. So hopefully comparing those two ocular problems, I'll say, just because myopia is not always a disease, if we compare both of them, the amount of visual impairment and blindness caused by each are about equal. The prevalence, obviously, in the future is going to be a lot larger for myopia and high myopia at that point, a lot larger than glaucoma. And I think with hearing that, it should be enough to kind of explain what the importance is in taking this seriously and integrating it into our practice. And if you're not willing to integrate it into your practice, at least being able to give the patients the information they need and referring them off to the right person if they are interested. Now that I've done my blurb on why I think it's important, hopefully I've got you all on the same wagon here. We'll continue going forward with learning different ways to modify our pediatric exams to better screen for myopia. So some of these things you'll see that we already do during our pediatric exams. It's not even adding on to your exam. Maybe just putting the explanation on why we do it, so better understanding. And if the parents ever ask you on why you're asking those questions or why you're doing the tests, you'll have the information and be able to better explain. So the first thing is just simple questions that you can add to your case history, or if you're already asking them, kind of better explain them to the parents and to the patient. And so the first one is the time spent outdoors. So it's a study that was done by Herdman and al. And what they kind of found was they first studied just using distance vision most. So they had children that were playing sports indoors and outdoors, only using their distance vision. And we're kind of under the assumption that if the children only use distance vision instead of their near vision, it would help prevent the progression of myopia. So they stay quite stable. And what they realized was in the indoor sport group, there was the same amount of progression as if they had done nothing different in their daily activities. But what they found with the outdoor group that were playing sports was there was actually a significant reduction in the progression of myopia. And so at that point, they started spending more time studying UV exposure and kind of concluded that it's not really using your distance vision more. It's the UV exposure outside that's actually beneficial for the eye and helps prevent elongation at that point. And so what they wanted to pull out of this study was really to try to get a certain amount of time that we can tell patients that would be beneficial for them to spend outdoors, so that we can kind of better educate the parents and give them something to take home with, because obviously it helps most if the patient is not yet myopic. So if you're able to do these screening tests and do see that the patient is at high risk for developing myopia, and on top of that, they're not spending a lot of time outdoors, it's something that you can add to your kind of conclusion to the exam and better explain it to the parents. And so what they found once they did decide that it was the UV exposure outside, they tried different amount of times. And what they saw was just an additional hour spent outdoors a couple times a week, so they didn't say a specific amount of days, was enough to really reduce the progression or the development of myopia at that point. So they were basing this mostly off of axial length, so not basing it off of refraction per se. So that's just a really easy question that you can ask right off the bat. Ask if the patients do go outside at all and how much time they're spending per week outside. I know it's hard in Canada with our different climates and having a limited amount of hours to play outdoors after school, but if you're able to boot them out there just a little bit longer, it may make a difference in their refraction and in their axial length. The next one is the number of myopic parents. So another similar study that was done on the COMET children. So the COMET children are children that you used in a study that's very, very popular in myopia management. And what they did during this study was they just compared, depending on the number of myopic parents, seeing if the patients were more at risk for progression. And so what they found was between 0 and 1 parents, there really wasn't an increase in risk. However, between 1 and 2 parents, there was a significantly large increase in the amount of progression. Something that you can ask, you can't really control the number of myopic parents, but at that point it might make you a little bit more worried if you do see that all the other screening tests are giving something that's a little bit abnormal or out of the normal ranges and stuff like that. You can say, on top of all of this stuff that's indicating that you might develop myopia, you also have 2 myopic parents. So at that point, we'll try to work on the ways to control the development of myopia. And near work, the reason I have not evidence-based is just, I think it's a question of time. There will be a study that'll show that there's a link. Right now, there's no strong link between the two. A lot of studies have been trying to prove that there are, but there's no amount of near work that's actually been linked to myopia progression per se. So I think it's important still to ask the question during our case history. We all have our patients that walk in where you see that the young kid is on the cell phone, and whenever you ask the parents, they're like, yeah, they spend their whole day up close on the tablet or on their cell phones, and they do end up always being myopic, almost always. So there is obviously a link, it just hasn't been proven yet with the studies. I think that we should stress the importance of visual hygiene. So even if you don't have a specific number that you can tell the parents, like not more than 3 hours a day, at least being able to tell them that it will make for a more fertile environment for myopia progression possibly, and just taking into consideration like the rules, like the 20-20-20 rule and stuff like that, and getting them to take breaks every once in a while so they don't fall into a spasm and just make for a more fertile environment, like I said, for myopia development. The next test that I'm going to go on to is the accommodative convergence on accommodation ratio. So it's something that's very easy to add into your exam. The reason I'm mentioning it right now is that there are multiple studies that have proven that a high ACA ratio, so above a 5:1, has actually been linked to the progression or development of myopia. And it can be found if it's found early enough. So it usually happens about a year or two before actually developing a myopic refraction. So if you can screen for that and you see that it's abnormally large, at that point it'll just make you more suspicious of maybe the patient being more at risk of developing myopia. Very easy way of measuring it. You're already doing your near cover test with an accommodative fixation target. All you got to do is just add on a +1 or +2 flipper and remeasure your near vision for you. And so EXO is minus, ESO is plus. Your initial, the formula is your initial formula minus your add FORIA divided by your add. So if you've had an ortho child up close at 40 centimeters, add a +2 flipper and they become 8 EXO, you have a 4:1 ratio. And so all you're looking for here is just an abnormally high ACA ratio. So that's something to take into consideration very fast to add onto your exam. Refraction, I'm not going to go over RET all that much because we all know how to do it. It was just to kind of remind people what the normal values are for age. Often we're just happy if the patient's not myopic, but there are normal ranges of hyperopia that you're looking for at certain ages. So this graph here just showing you that between the ages of 0 to 3, you should be expecting hyperopia to be higher than +1. So anything that's +1 and below, you should be a little bit suspicious. As well as the ages to 4 to 6, you should be suspicious at +0.50 and below. And after that, it's basically ametropia, so plano. Lag of accommodation, I know a lot of people don't like when I talk about this. So dynamic RET, most optometrists haven't heard about this since school. It's something that we don't do very often, but it is very easy to do. And once again, all you're looking for is an abnormally large lag of accommodation. So all a lag of accommodation is basically when the patient is focused or reading at near, it's how much their eyes are lagging in accommodation. So how much their defocus, their hyperopic defocus is up close. As we'll talk about in the myopia control options later on, what we usually work on to try to control progression is correcting for the hyperopic defocus in the periphery of the eye. The reason for that being that we think that that defocus is actually what's sending off a signal to the brain to help elongate the eye. And so if we're so worried about that, we should definitely be worried about if there's a hyperopic defocus centrally as well, because then the peripheral one is just even worse. So something very easy to do with your RET, you just add on your fixation target that goes on top, or you use just a fixation target, or you put a sticker on the tip of your nose. The patient has both eyes open. You get them to fixate on that image, and with loose lenses or a lens bar, just go over one eye at a time and RET a little bit. You should be expecting it to be neutralized at around +0.25 to +0.75. If it's above +0.75, you have an abnormally large lag of accommodation, and at that point the patient is a lot more at risk for developing myopia. There's been no studies that have proven that VT, so vision therapy, working on patients' binocular vision is linked with actually lesser risk of developing myopia, so I'm not going to get into that. However, I do think that these 4 little screening things that you can do during your exam, if you just take them into consideration, you may possibly be able to advise the parents and the patient that they're more at risk for developing myopia, and then at that point pushing a little bit more for visual hygiene, time spent outdoors, and just being careful coming in a little bit more frequently, and maybe possibly getting an axial length, as I'll mention later on. So now that we've learned what we can do to screen for it, what needs to be included into your myopia management exam if you really want it to be the standard of care. So do know that if you're not wanting to do any myopia management at all, and you say, it's just not my clientele, and you want to refer off, all these tests, especially the screening ones, should be included in a myopia management exam as well. So there's something that the optometrist should be doing regardless. So if you're not interested in doing it, don't worry about it. Something that you can just mention off to the parents and let them know that it will be done. So the first thing that needs to be included in a myopia management exam is a cycloplegic refraction. The reason I say that is there's been multiple studies that have been published that are saying that overcorrecting or undercorrecting a myope is actually leading to more progression, so not doing any good for the patient. So if you undercorrect myopia, you're leaving the patient in just with uncorrected refractive error, so they're seeing blurry regardless. And that blur of the eye is having a hard time with knowing if it's a hyperopic defocus or not, so tends to make the eye elongate anyways. So there is studies that have been shown that undercorrecting the myope at that point can lead to myopia progression, as well as overcorrecting a myope. So overcorrecting a myope, what you're creating is a hyperopic defocus that we dread so much. So this is the importance of really going and doing the cycloplegic refraction and getting the proper amount of myopia, and at that point, maybe reducing the risk of progression. The gold standard is 1% cyclogel, so 2 drops in each eye. However, there's a recent study that was published by Sandiaz and colleagues that show that 1% tropicamide in myopes that are above 0.5 diopters was actually equivalent to cycloplegic refraction with 1% cyclogel. So at that point, the patients like you a little bit more. It works a little bit faster, and they don't have any near vision symptoms the next day when they go to school. So it can make your myopia management exams a little bit more bearable for the patients and a little bit faster for you as well. Below the minus 0.5 diopters, it's just that there's too much residual accommodation for it to actually be considered a cycloplegic refraction. And that's that. And if we go off to the axial length now, once again, this is something that we don't think of doing when the patient's not yet myopic, but it is something to consider because axial length has been shown, an abnormally large axial length can actually present itself a year or 2 before the patient actually develops myopia. So this is the importance of getting it done. And we've recently come out with growth charts now. So depending on if the patient is Caucasian or Asian or other ethnicities as well, there are growth charts where we can place as per the age of the patient and their current axial length. That gives you kind of a progression and their amount of risk of developing myopia or high myopia. So just getting that right off the bat, if the patient's not yet myopic, you can kind of show the parents where they're heading. So it's a very, very good tool that you can use to better explain in your exams when you're not actually doing any myopia control options, so glasses and stuff like that, because they don't have a prescription yet. Just showing them this axial length, the growth chart should really give them a better understanding of what's going on and what to expect in the future if nothing is done. If you're doing myopia management, the standard of care is that the axial length should be monitored every 6 months. I know when I mention this, a lot of optometrists will say nobody has access to a lens star or myopia master and stuff like that to get the axial length done. I think this is a good opportunity for you to maybe better have a better bond with your local cataract surgeon and maybe ask if you guys can partially use the lens star at that point, even if it's for a fee or something. If they know that you're helping prevent myopia, maybe they'll be able to cut you a deal and get an axial length from here and there from their center. Or if you're in Ottawa, you're in luck because we have the myopia master here now at PCC, and we'll be accepting referrals for that. So if you just need the axial length, that can be done here as well. If you're wondering what normal axial length is, so the progression per year, you're looking for about a 0.1 millimeter a year. When the patients are young, so before ocular maturity, around 20 to 25. A diopter for the younger patients is equivalent to an increase of 0.028, and from 12 to 13, so a little bit older, about 0.32. So most of the time people will say a diopter is about equal to 0.3 change in axial length. So as well as the other important factor of getting axial length done for your myopia management is sometimes the axial length can still progress and the refraction can stay the same. So you might think you're doing a really good job, but in essence, there's still a large progression happening, and the refraction has just not yet had time to change. If we go over the growth charts, so this is by Tagman and colleagues. So we have the girls that are on the right side and the men that are on the left, or I should say the boys on the left. And so what you're doing is basically looking at the age of the patient, the current axial length, and it gives you the projections for in the future where the prescription's heading. This is used for all ethnicities other than Asians. So the Asians have their own growth chart done by Sandias and colleagues, just because their axial length changes really drastically and is at a lot larger rate than all the other ethnicities. So they've got their own growth chart. All right, and so now if we go on to the current treatment options that are available for myopia management, we'll look at all 4 different options, and as well as who's the best candidate for each option and the percentage of control that you'll obtain with each treatment option. So if we go on to the first one, which is myopia prevention spectacle lenses, there are 4 on the market that are actually marketed for myopia control. The first one are progressive lenses. So the reason I have same progression as single vision is because beforehand there really wasn't one that was branded for myopia control. So they were just trying it out with different amounts of ad in the progressives. And it was the amount of control was about the equivalent of single vision. So it wasn't doing all that much. The Myopia Pro is a lens that's marketed for myopia control by Essilor. What it's been showing is about a 30% control in the progression of myopia. It's not the best one. You'll see that there are better options available. However, the fact that it is a progressive lens, it does correct for large EZO and helps with patients with large lag at near. So sometimes it can still be the best option for your patient if they do have a fragile binocular vision, where you're kind of worried they might decompensate if you put them in contact lenses or just atropine alone. The second option is executive bifocals with base and prism. They work wonders for your large exos or people who have large ACA ratios or convergence insufficiency, but they are not nice to look at. So they're an executive bifocal with a big line. Your young patient really looks like an old little man or an old little woman when they wear them. But they do work really well for the patients who you need to do a little bit of myopia control and at the same time have an abnormally large exophoria and might start seeing double if you put them in contact lenses or in the other spectacle lenses. And so at that point, the base and prism, there's about 3 base and prism in each lens. So it really helps to correct for their exophoria and really gives them a little bit of a break up close. And the amount of control that this lens offers is about 35%, so a little bit better than the Myopia Pro, but you'll see it's not the best option as well. So these 2 first options are really if your patient has an abnormal binocular vision, they're good lenses for those situations, and both of them are by Essilor. If we go over to the peripheral defocus lens, so like I was mentioning, what we worry about is often the hyperopic defocus in the periphery of the eye, leading to myopia progression at that point, so sending off a signal to the brain to help the eye elongate. So a lot of the techniques, these 2 last ones that I'll mention, as well as the contact lenses, all work on controlling that. And so the peripheral defocus lenses are the MyoVision lenses by Zeiss. They're kind of one of the first lenses that were marketed for myopia control. They don't have a very high ad in the periphery, and for that reason, there seems to be not the best results with them. So if you look at studies that are actually industry sponsored, obviously they're showing a lot better control, but in the studies that are comparing different products and stuff, they tend to offer about a 20% control in myopia progression. There's no BV recommendations for these lenses as well. The last one is the newest one on the market, so the DIMS, which is Defocus Incorporated Multiple Segments. It's a MyoSmart by Hoya. So what it is a 9mm central zone in the lens that's nice and clear with the patient's prescription, and in the periphery of the lens it has all these honeycomb little islands that are spread out with plus 350 ads, so quite a high ad in the periphery of the lens. And between the islands is the patient's normal prescription, so it's not supposed to affect their peripheral vision when they're looking to the sides, but still supposed to correct for that peripheral defocus. And so patients tend to really, from what I've heard with the patients that have been trying them out, is they like them a lot. You do see the honeycomb design though, so some people don't like that. but they're the ones that have been offering the best control. So they're at about a 62% control in myopia progression. And so if we look at this is just to give us a brief overview of all the different spectacle lenses that are marketed for myopia control. The first ones being the progressive lenses. So those were just any old progressive that they were trying to do with different ads to see what the control was, and getting variable results anywhere from 0 to about 30%, give or take. And then if we go off to the ones that are more marketed for myopia control, the MyoVision at about 20, Myopolix Pro at about 31, 35 for the executive bifocal, so Myopolix Max, and Hoya at about 62. So that's the one with the little islands in the periphery. Now, if we go off to the second treatment option, we have low-dose atropine drops. And so Adam's one was the first study to actually take into consideration using atropine in myopia control. And so what they used was a percentage of atropine that we use for amblyopia, which is 1%. What we found was it worked wonders for controlling myopia. However, the patients did not want to be on 1% atropine for a long time in both eyes, because at that point they were having to wear a progressive or bifocal anyways, just because they couldn't see up close. The pupil dilation was really bothersome for the patients outside, so very light sensitive. And what usually happened is if they started off the atropine at a pretty young age, they stopped it before getting to ocular maturity, and at that point what would happen is you get this huge rebound effect where all the myopia would come all at once, which isn't better. If you were able to help it not progress all that time, then all of a sudden you stop your treatment and it bounces back. You're not doing any good for the patient. So they technically have to continue that 1% atropine until they reach their ocular maturity, and that was just unrealistic with the near vision symptoms that it gives. So what they went on to study is lower concentrations of atropine and seeing if it had the same effect on control. Obviously a little less effective, but still obtaining about a 30 to 50% reduction in the progression of myopia. And so the currently accepted concentrations are anywhere from 0.05% all the way to 0.01%. The most recent studies, like the Lance study, which is low-dose atropine for myopia progression, shows that 0.05 has actually been the most effective way to prevent myopia progression. With little to no rebound, and all three of these concentrations still leave the patient with 12 diopters of accommodation and less than 1 millimeter pupil dilation. So not many side effects. You'll see that a lot of optometrists are still prescribing 0.025% when they're using them as a synergistic treatment with spectacles or with contact lenses, so it works really well. However, the most recent studies, I would say that they've proven that 0.05 has just that little step up on the 0.025. The 0.01% was previously used, but it's just not a significant amount of prevention that's offered with that low of a dose. So better than doing nothing, but you might as well just up it a little bit if you do want to get the proper control and progression. The mechanism of action of low-dose atropine in myopia progression has not actually been determined yet, so they're still studying that. So I have no information to give you on how it works, but you know that there's been a lot of studies studying it, and it does work really, really well, so anywhere from 30 to 50% reduction. And it's most of the time used as a second option for the treatment, so an option that you add on to the current treatment option, just because the children, obviously you have to correct their myopia regardless, so you're going to put them in either a myopia control lens or in myopia control contact lenses most of the time, and if you're not obtaining the proper control at that point, you add on the atropine just to go get that little extra and really decrease the progression at that point. But if you do have a patient that walks in and they just invested in new glasses and the parents are like, there is no way we're buying new glasses right now, it could be used as a first option. All right, our third option is soft contact lenses. There's only one soft contact lenses that actually is FDA approved for myopia control, and that's the MySight lens. How it works is you've got your center distance in the center part of the contact lens, and then a bunch of concentric rings that are kind of variation between high ad and the normal prescription. And so what it's doing once again is correcting for the peripheral defocus while leaving little rings in between with the patient's normal prescription, so it's not affecting the peripheral vision all that much at that point. It's shown about a 60% reduction in myopia progression, so quite an effective treatment. They're daily disposables, but usually what the limiting factor is for these lenses is just the age of the patient, so not many parents like patients wearing contact lenses at such a young age. You also want to be careful if they have abnormal BV, just because large exos, large lags and stuff like that, they won't like being in contact lenses. You're taking away their base and prism from their glasses that they normally have. And also myopes accommodate more in contact lenses than they do in glasses. So just keep that in mind if ever you find your patients having a hard time eye strain and stuff like that, adapting to contact lenses, it might be for those reasons. If you're using any off-label multifocal contact lenses to treat for myopia, there's been a lot of studies with the ProClear multifocal, which is not marketed for myopia control, but works pretty effectively. So not near the 60% reduction, but they're showing pretty promising results around the 30 to 40%. So it could be a good option if you don't want to bring in a bunch of stuff for myopia management because you only do it occasionally. As long as you have those ProClear multifocals or any other multifocal lens that has a center distance portion in it would work pretty well for myopia control. So if you only have the center near in your contact lens, at that point you're just not correcting for the peripheral defocus and not doing the patient any good. The last option is orthokeratology lenses. So this is reverse geometry lenses that are used at night to sleep with, so the rigid gas permeable lenses. Once again, what they're doing is they're remodeling the epithelial layer of the cornea, and by remodeling it, creating a really high add in the periphery of the cornea, which is correcting for that peripheral defocus, and at the same time is kind of flattening down the center part of the cornea, which corrects for most, if not all, of the patient's refractive error. And that's not the goal of the orthokeratology lenses. It's not to correct the prescription. It's really to create that defocus in the periphery, but it's kind of like a side effect that a lot of patients like from the lens, that they don't have to wear glasses during the day. So these are worn overnight. The reason I say it's off-label is just because beforehand there was no FDA, there's a lot of non-FDA approved lenses that are used for orthokeratology. However, now it is actually FDA approved, and there are a couple lenses on the market that are FDA approved for it. There isn't really that much of an increased risk for microbial keratitis with contact lenses. The one that I found for orthokeratology was about 7.7 people on every 10,000 years of wear. So not all that frequent, but still something you have to take into consideration with contact lenses that it is on the cornea. And so if the patients are young, the parents have to be on top of keeping these orthokeratology lenses, since they're not daily disposables. They have to keep them clean and make sure they're taking good care of them, make sure they're not scratched or chipped or anything like that. But it would be best if they were daily disposable, obviously, like the MySight. It's still a very, very good option, about a 60% control. All right, and so before I finish up, just a brief overview of what we saw. So we were able to see what the prevalence of myopia causing low vision and blindness right now is in North America, comparing it to the trends in 2050 and seeing how much it's going to progress from now forward, and how a lot of specialists are now calling it the next epidemic. So I think this is why we take it maybe a little bit more seriously, and hopefully by comparing it to glaucoma, it was as eye-opening as it was to me when I was first presented it that way. After that, I hope that all that information kind of made you more excited about incorporating myopia management, or at least screening into your pediatric exams, and knowing what we do when we do those myopia management exams if it's not really something that you're interested in. Knowing who's more at risk, what questions to ask, and the really fast little screening options that you can go. The importance of getting axial length done, whether you're doing the myopia management or getting it done just beforehand. And also the importance of cycloplegic refraction, and getting a brief overview of the current treatment options that are on the market for myopia management, depending on what your patient's binocular vision is like, how comfortable they are with drops and with contact lenses. So being able to have a bunch of tools in your toolbox and not only one option available. So thanks for listening.
Awesome, that was great, Brittany. Can you hear me okay?
Yeah.
Okay. Hear me okay?
Yeah.
Okay, so that was great. Thank you so much. I have to, I was just thinking I should revisit my pediatric exam, which has been something I haven't done in a whole long time, but I'm glad you're around to do it. So these are really nice key points. I think it was nice that you kind of put it in perspective in terms of what this means for the next few decades. So my question is, how do you, like, this makes sense at, the science level, but what do you tell parents? Because parents may not know about, special glasses or contacts or drops for kids for myopia. So what's involved with educating parents?
So what I do normally, now that I've started off and doing a little bit in private practice, is I obviously include all the screening things that I talked about beforehand, but I really stress the importance and talk about other ocular diseases that can be brought on by being myopic, because often what parents think of is just like, well, a pair of glasses and they see fine. Like, I don't understand why we have to worry about this so much. So I think really educating them on the risk later on in life really enlightens them, and they realize, oh, I didn't know that it was this dangerous. Or even just explaining that myopia is a bigger or larger eye. A lot of patients don't even know that right off the bat. So once you start telling them, you know, it's usually an abnormally large eye, and the higher the prescription goes, the bigger the eye is, the more stretched out the structures are inside like the retina, and then making you more at risk for other ocular pathologies. Usually that's just enough to get them on board. But obviously, once you start talking, if they are on board, start talking about the simple ways that they can maybe reduce the risk, they realize that it's not all that hard. And if they are already myopic at that point, showing them the importance of axial length, and if you have access to axial length, and showing them the growth charts, I think that would be the best way to get them on board, because there's nothing more than saying, this is where your child's at, this is where they're heading in a couple years. So usually that'll sell parents on it.
Okay, and so for optometrists, how I guess these patients are in your offices, you know, getting measured for glasses or whatever, or and so is that the main way that they would come across an optometrist that does myopia screening, or are most of these people who are doing myopia management and have the tools and all that, are they basically in a separate category of optometrists?
I'd say beforehand there were only a few optometrists that were really willing to do myopia management, and I think that's just because we maybe didn't understand the importance of it, or what the projections were in the near future. And now that everybody's on board with that, you will see a lot more optometrists advocating for myopia management. So I think it's, beforehand it used to be just only a couple optometrists that were doing it, and they were in, you know, specific centers that had access to all these tools. But little by little, optometrists are starting to do small things in their clinic to better control. So if they do find a patient with a myopic refraction that's changed over the year by about a diopter, none of them will hesitate by offering a lens that's marketed for myopia control at that point. I just think that we have to even emphasize a little bit more of the importance of including everything to make it the standard of care for myopia management, because it may seem like the control is really good, but without having all of the pieces of the puzzle, it's really hard to see if it's working or not. But I think that now, compared to beforehand, there are starting to be optometrists just in private clinics that are wanting to do this as a subspecialty and take into patients. I don't think there are a lot of them that just do it every once in a while. People usually have to have an interest in it, and then after that develop a clientele.
Okay. And then how would you capture those patients that have very little myopia, but they may have, as you mentioned, some things like the ACA ratio is changing, or you're worried about issues that may put them at risk for myopia, but they're not showing myopia?
So if you're not doing the screening tests that we talked about, everybody's doing RET, and if you're retting, you should be taking into consideration if they're within the normal range that you're looking for their age, because often I think what happens is we're just happy as long as it's not myopic, but that's really a key factor. If you're able to see that they're at plus 0.50 and they're only 3, that's really abnormal. You should be seeing like plus 250, almost plus 3 at that age. So just that, if you're not doing the screening test should be enough to kind of trigger maybe a little red flag, and at that point be a little bit more cautious and possibly do some further testing. But picking up on it, I mean, if you're asking the questions, most optometrists will ask those questions regardless. I think sometimes it just takes a little extra information to understand why you're asking them, or just better understand what you can explain to the patients after asking the questions. But yeah, the questions and RET would probably be an easy way to try to target these patients.
Okay. And as myopia management programs become a bit more established and we hear more about them, what role, you mentioned the role of, say, ophthalmologists and, say, getting axial length measurements, but how do you kind of see the larger role of ophthalmology, and perhaps in particular pediatric ophthalmologists, working with them. So how do you see that relationship coming about?
So I think that in the beginning it might be a little bit rough, but what we have to take into consideration is try to forget about myopia as just being a pair of glasses will correct it, and trying to think of it more as an ocular disease. And at that point, it might be taken a little bit more seriously. And knowing that if it is progressing, even if a new pair of glasses is going to give them 20/20, that they should be managed by somebody who wants to do the myopia control or help reduce the progression. So if it's an optometrist that's working with a pediatric ophthalmologist, maybe the pediatric ophthalmologist taking into consideration the change in refraction instead of always just looking at fundus and stuff like that and only taking into the ocular disease portion, but actually looking at refraction each time, and if they're seeing changes, collaborating or co-managing with our local optometrist to see if any of the myopia control options would be good for that patient. But I do think there is a lot of possibility of co-managing these patients together, just like we do for glaucoma. I think it's just going to take time before it starts, but I think it'll become pretty frequent.
And what countries in the world have done a really good job, and which countries should we kind of look at their practices to model our practices after?
So obviously, anywhere in Asia is probably where all, if not all, almost all of the studies, the best studies on myopia control, myopia management have been published. And so I think just because they have a population that's so much more at risk and the prevalence of myopia is just so much higher, it's just something that they didn't need to wait to hear a study say that in 2050 it was going to be bad. It's already pretty bad over there. So at that point, I think they've just got a head start on us. And they've been really good to integrate a lot of myopia management and control into their practices. So obviously they would be the experts. We get a lot of the information from them.
Okay. Any other questions from the other attendees? You can either type them in or just let us know. Okay. Well, I think that was a really nice overview, Brittany. Thank you so much. I definitely will be thinking about myopia in a different way. And it's funny, as I mentioned before, as a refractive surgeon, you think about myopia, and usually when you are beyond ocular maturity, right? For, say, laser vision correction, we think of myopia or refractive error a little bit more when we think about presbyopia and cataract surgery later on, and refractive lens exchange procedures. But I guess really looking at the earlier age groups is going to be super important, especially as you mentioned, when you think of it as the possibility of preventing other ocular diseases. It's a strong argument. So thank you very much for letting us know about all this. Of course, you had said before that you gave permission for this to be recorded, that this will be available for other people to listen in on our YouTube channel. But thank you so much, Brittany, for your time and for enlightening us about the myopia management.
Anytime.
All right. Have a good night. Thanks. Bye, everybody.